So it's my very pleasure to announce my co-partner here, Dr. Mantry from UK, and he's going to talk about spherical aberration and how are they shaping the future. We know that a lot of us do not understand too much about aberrations, so I'm sure this will clarify for us this story. Thank you very much.
Thank you, Doctor. Good morning, everybody. I'm delighted to be here from Vision Scotland and see this first refractive Zagreb meeting. I am a financial disclosure first. I'm a paid consultant to Alcon and Rayner. I think, so to give a bit of a background about me, I'm a consultant with cornea, cataract, and refractive surgery interest. I've worked in a teaching hospital in the NHS for about 20 years. Main interest was corneal transplant, whether it's lamellar keratoplasty or DMEC or DSEC. But laterally, I've moved to a private sector, having Vision Scotland in Central Belt and North of Scotland, offering private eye surgery for cataract, refractive lens exchange, refractive surgery, retinal surgery, the whole range, but privately. I think we all know if I think about my practice change in the last 10 years, if I had a patient with cataract or wanting lens exchange, if I think about somebody who's coming to me and said, I want my distance corrected, the main portfolio for me was always a monofocal or a monofocal toric lens. If they wanted a presbyopia corrected, if I think about 2 years ago, my probably practice was about 50% of these patients who were suitable to have trifocal lens. But what I found in probably the last 2 years, since the new technology has come in and we are able to adapt it and be less compromising for patients, I feel that the 50% of trifocal has now moved into almost 85% into the bracket of these extended range of vision patients and less of trifocal. Now, you want to do the best for your patient, and you want to therefore understand what's going on with this extended range of vision, because at the end of the day, a happy surgeon is only happy if you've got a happy patient. And I think all we want to do is basically give them the best technology that's out there. So I'm going to spend a bit of time. So the only two, there are few in the market, extended range of focus. You can call this in a very different name, extended depth of focus, extended range of focus. The two main I use is a preloaded hydrophilic RayOne EMV and a non-preloaded, but basically hydrophobic Vivity lens, which is a UV filter. These are the two lenses I've got experience about, and I'm just going to share my experience about EMV a bit more in detail. Now, if you think about, so you go away thinking, I want to know about this extended range of focus. What does every company tells us? So I think there is kind of eruption of technology or words that every company will use. And I think whether it's wavefront stretching or X-wave technology, or it's range of focus for EMV, or it's you're altering the spherical aberration, whether it's positive or negative, there are various ways you can achieve this. The first, I would say, technology that came onto the market was actually Symphony, which is a bit of a hybrid. It was the Eschlet technology, but the biggest loss there was it still had said multifocality. So there are a lot of patients who, what we found was they were not getting reading as good as a trifocal, but actually were getting a lot of glare. And that's where we moved away from it. But the terminology, in my opinion, is quite confusing, but the best way to understand is to understand spherical aberration. So I'm going to spend a bit of time understanding that. So what are the two categories of technology that's available? I said wavefront focusing or wavefront with Vivity, which is, you can say, X-wave technology, or either they use positive or negative spherical aberration. So negative spherical aberration, if you look at, are you've got IsoPure, you've got iHands, you've got LuxSmart. They all use negative spherical aberration. I'm not going to go too much into that, but I'll go into positive spherical aberration and how we can use it to the benefit of our patients. And the RayOne EMV uses that. So if you've done both these lenses, you will see this difference. And I think the reason I'm going to spend a bit of time on that is to make, so if you look at this, this looks like a monofocal lens. If you said anything otherwise, raise your hand. I'm happy to, but I think this is truly looking like a monofocal lens. This, actually, if you put it in, it looks like a monofocal lens. If you slightly tilt it, or sometimes the patient looks up or down, you will see a bit of a depression or diffractive ring. And I don't know how many of you went to ESCRS, but there was a bench study presented by Damien Gettinel, and I thought that was very interesting. And actually, if you look at this bench analysis of these lenses, you see this flatter, so the distance is right in the center, and then you've got this gentle curve, which actually, the main difference here is this area here in the vivity, where there's almost a 1 micron rise in that bench analysis, which kind of corresponds to the diffractive ring and can give you some dysphotopsia. So it's quite an important thing that in the bench analysis, it shows that there is some degree of diffractive in this ring. But how does it do what it does? So for eye, we know as you're getting older, the two aberrations in the eye is corneal spherical aberration, which is about 0.27, and the negative spherical aberration caused by a natural lens. Now, the natural lens of a 25-year-old versus a 50-year-old, that negative spherical aberration keeps on getting, or it gets less and less along the way. So the positive spherical aberration then becomes, is the bit which gives you a bit of pseudo-accommodation. So all the monofocal lenses just use positive spherical aberration from the cornea, but if you were to add a positive spherical aberration to this in the therapeutic range, then what you will get is the circle of least confusion. So this area where it's saying 1.5, that's the circle of least confusion. And you really wanted to have that range and use it to benefit for the patient, rather than just a 0.5, which is the pseudo-accommodation you can get with any aspheric monofocal lens. And I think the simple idea of this was put along by Prof. Barrett, and he's obviously patented work with Rayner, and effectively what he's done is using this as a platform. But the biggest advantage, I would say, is it does behave like a monofocal, i.e. it is very forgiving in terms of tilt, decentration. The dysphotopsia is minimal. And I think that's kind of the key, where as surgeons, we feel we can predictably tell the patient that there's less risk of dysphotopsia, and it's actually all benefit compared to a monofocal lens than a multifocal lens. So just to get a bit more deeper into that, I've got some colleagues who say, well, why use an enhanced monofocal lens? Why not just go for if somebody tolerates monovision? So if you look at this, a standard monofocal, the biggest advantage is you've got this MTF curve, and you see a very, very sharp distance, but it quickly falls over. So there's no range of, if that's the, on the left is the distance and on the right is the near, it just falls very quickly. How does a positive spherical aberration in EMV causes this to be better? All it does is it flattens the distance bit more towards myopia, so you're flattening and moving it across. But more importantly, the near bit, or the distance bit, there is like a hyperopic tail. So it flattens it moves it more towards the distance, so it does not compromise the distance as well. So the difference between this and this is, though it's flatter, but it's broader, and it moves towards myopia and with a hyperopic tail. Now that's used very well if you look at the monovision. So if you had a patient whom you wanted to do dominant eye for plano and non-dominant eye for -1.5. So that's kind of the monovision that you would want to go. The only problem is they do very well. They do very well for distance. They do very well for here. But all this range of vision is empty. So that's where the blend zone is minimal. Now, with the same principle as spherical aberration, how positive spherical aberration is helping, if you think now the difference with a same plano for distance and monovision for the non-dominant eye, because of the hyperopic tail, you actually end up having a much, much bigger blend zone, but not compromising the distance as well. So this is where I think all this EDOF technology has been very helpful for us. And I think this bigger zone is again thing that if you were doing laser and presbyon, that's where you kind of think you want to be in that blend zone where both the eyes work together, but actually it does have a range of focus rather than a very sharp sharp distance, but nothing in between. So I hope that makes it a bit more clearer for you. If you are one who's starting to think, well, I have never done EDOF technology, I want to start it. So for me, I think this is the full range that you would want to think about. You can either do emmetropia for both eyes. I think most people would prefer. So if I was the surgeon starting a new EMV or Vivity, I would just do a good dominance test, do a dominant eye for plano and non-dominant eye for -0.5. Do not promise the patient anything more than 0.3 logmar, like N10, and 6.6 to 0.00 logmar. I would say if you are promising that region, the risk of you inducing any risk is much less, but actually then you can build your confidence up and start doing more with it. So for me, I would say a modest monovision will go up to -1.25 in the non-dominant eye, and a full monovision is -1.5. And with that blend zone, you can actually make it work, and I've got some results to show that. I think we all know, and toric lens is probably a discussion on its own, but for any premium lens that you use, whether it's trifocal or extended depth of focus or extended range of vision, you need to not kill the cell, but you need to reduce the astigmatism, because otherwise, if you don't have the sharp focus, it will probably, it will not give you the result that you want. So for me, if you got anything astigmatism less than 0.75, I would actually either go on axis or do flex, femtosecond guided limbal relaxing incision or arcuate keratotomy, depending on what the patient is. But now both these lenses, EMV or Vivity, have toric platform, and the results are very, very good, and it's very stable. We all know from their monofocal counterparts that the toric lens is very, very stable. So quite confident but you need to, the only place where, so I think if you've got astigmatism on a corneal plane, which is more than one, and it's against the rule, like a horizontal axis, you need to use a toric lens. If you don't have toric lens, I think you will not get the result that you desire, and I would rather stick to monofocal toric lens and say we cannot give you distance vision. I think if your toric lens can't be, or astigmatism can't be corrected, I don't think you'll get the desired outcome. If you do have some residual astigmatism against the rule, sometimes the circle of less confusion and optically the strum of conoid can give you a bit more depth of focus. So I think if you had some residual astigmatism, it will work. But usually you'd want to reduce the astigmatism while you're doing these premium lenses. I think with all that said, I think I'm going to present my 100 eyes with EMV that I've done. And I think it's quite important to, though you ideally want binocular vision, it's important to say that it is very, so if I was to say the color coding, emmetropia is the blue on that. The light blue is monovision, mini monovision, which is about -0.5. And the orange one here is modest monovision, is up to -1.25. And the full monovision is the pink there. And you can automatically see, unaided wise, the distance is the best in the emmetropic group, and the near is the best in the full monovision group. That's understandable when it goes to unilateral. But life is not about unilateral. You don't walk with this one eye like that. Life is about binocular. And I think it's very interesting for me, even as a surgeon, if you look at the one on the left, it's quite important because even if you've got full monovision there, it's not actually affected the distance. If you look at this graph, binocular unaided distance vision, they're all hovering around 0.000 logmar. So your distance is not compromised with both eyes open, which should give us a confidence thinking, actually, if the patient is very, very keen on reading and will adapt a bit of a monovision, then I think you can stretch the monovision with more experience you've got. The other thing which I feel is very, very good to say here is overall, the reason I've put both logmar and N is I understand in Britain we still use N4, N5 for reading, and I would say almost 100 patients, 100% of the patients got better than N6 or better, which I feel is something which you can almost coming very, very close to a trifocal vision. However, the trifocal doesn't give you, well, the risk with trifocal and the glare is massive. Now, on that point, I would say trifocal is not there. I've done my business partner's mother and mother-in-law both with trifocal, and they're the happiest patients. They basically, they know I like my wine, and they basically send me carrots of wine, and it's coming every 6 months, so they must be happy. So I wouldn't discourage you to use trifocal, but wherever you feel either you're coming into the presbyopic market, or you actually think, I don't want to take a risk about somebody depending on like a commercial pilot or somebody who's an HGV driver, you don't want to take a risk of trifocal in that. Whenever you try a new lens, and for us, when we were trying EMV, you always want to make sure you optimize the constant. So I'm working with Prof. Barrett and Rainer to optimize my constant. I think overall, it looks like the EMV is fine. EMV toric, we may have to slightly reduce the A constant, but I would strongly encourage you to collect your results and actually optimize your A constant, whichever lens you're using. And I think, that's for all of us. Just putting it another way, I just think I'm going to just not keep on hovering about the results, but just to say, overall, 100% of patients were getting as good as 0.1 logmar, and for near, 92% got better than N8. And effectively, what it gives me the confidence is somebody who's coming to you and saying, I want to get this lens, but I want to do all my normal activities, like seeing the dashboard, watching the phone, and the smart, a smartphone, and they're reading the text. That's actually pretty much most of our life nowadays. That's what we do. This dashboard, driving, and it doesn't give you dysphotopsia. So I think it gives you the confidence that all these lenses, extended range of focus lenses, are actually here to stay, and we just keep on working on it and make it bespoke for patients as we go along. So I think before I finish, I just thought I'll share with you this result from Oliver Findle, president of ESCRS, who presented in ESCRS, and I like this graph. And he compared the photopic and mesopic, so during light conditions and during dark, between EMV and Vivity, the two lenses that most people are using at the moment. And I would say, overall, as you would expect, the distance and intermediate is the same. The near is slightly better with Vivity, and if you compare that with the halometer or dysphotopsia risk, they're statistically significantly higher in Vivity, which actually kind of ties in with what Gatinal said as well, that there is a bit of a diffractive ring. It has slightly more risk of dysphotopsia, but gives you a bit better reading in that scenario. So it all probably ties up in terms of objective bench analysis versus subjective what you see in real life. And I think if you just need to put, I think we should give our patients the best choice that we can, depending on what they want, actually. So depending on what their job is, you can use these results to your benefit. I think I've got a couple of cases just to show that where we've moved from trifocal to giving. So if I had a commercial pilot before coming to me, coming for a refractive lens exchange, I don't think I would have considered them suitable because I couldn't have given them a trifocal, because you cannot give glare to a commercial pilot and then go on that plane to going to Singapore on that flight and he's got glare. You don't want that. So this chap, as a self-referral, he came along, he said, I'm a professional pilot, now RLE is allowed. He had gone on the FDA website and he had said to me that the two lenses I'm allowed to have is either iHands or EMV, because it's enhanced monofocal and it's been allowed, so the commercial pilots are allowed to have it. So he came to me saying, I can either have these two lenses only. And very surprisingly, there's not many opticians who use EDOF contact lenses, but he actually was using EDOF contact lenses. And he said, I've adapted really well to it, so I'm going to try this. Anyway, for me, I think as a refractive surgeon, I think the challenging thing was he wanted vision correction. Obviously, he had a demanding job. He really looked for precision. Commercial pilots are very they are obsessed about things, and that's how they are what they do. So it was quite tricky for me to get this, but I did. So my plan was to do the dominant eye, aim for plano, and the non-dominant eye for minus 0.25 or minus 0.5. However, he did say to me that he cannot have the non-dominant eye or any eye unaided 6/9 or worse. So basically, he ended up having emmetropic in both eyes, and I'm pleased to say that was his level of vision. And he's given me, again, he's given the team and everybody so many thank you cards that he's been delighted and he feels has been, and I think more commercial pilots will come along the way asking that, because this is something which, but we couldn't have done that for trifocal. I think we all are nervous when it comes to the patients we have lasered or somebody else is lasered and then they come with a cataract. The problem with that is they still want absolutely spectacle independence, because that's why they got the laser in the first place, and they become a lot more difficult. So this 65-year-old, the right eye was the dominant eye and the left eye was the non-dominant eye. The left eye had good vision, had very early cataract. So I had said to him that I probably would be able to do an EDOF lens for you, but if I don't get my precision right or the refractive result right, then I might actually have to do the other eye to balance the two eyes together. And the only thing I don't have here for this case is what was the corneal spherical aberration on the pentacam. I think it was still in the therapeutic range, and that's why I decided to add the positive spherical aberration. So we did with EMV toric, and he was 6/7.5 and N6 unaided with that eye, and he decided not to go ahead with the other one, which actually, in my opinion, was a very good result, because I had to do the other eye only to make sure with both eyes open they will be fine. So the dominant eye then was almost around 0.1 logmar and 0.3 in terms of reading, and he was a happy patient. One last case, this 83-year-old, normally, if you've got cataract, we've got very, very early dry AMD, the more OCTs we do, the more epiretinal membrane we see. Not very, very subtle, but actually, when you've seen it in OCT, you've got to document that there is an epiretinal membrane. Patient is not symptomatic, there's very less clinical signs, but OCT is showing you a bit of the fovea is not right, and there's a very early epiretinal membrane. Previously, I would just do a monofocal lens on this one I did an EMV for this one, and he got bilateral cataract surgery the same time with EMV toric, and again, there was a dry AMD, so I'd always said you would not get 20/20 vision, but actually was very close to 0.1 logmar distance vision, and I think it expected, I think the expectation was exceeded in patients' words. So I think if any one of you are thinking of doing extended range of vision lens, I would always say you could actually make it very, very specific for or individually or bespoke make it for patients. If they're really pilots, they don't want any compromise with their distance, like HGV drivers, pilots, I would say aim for plano. If you've got golfers who really want to have a round of golf and then have read the paper and want the dashboard, you could do a micro monovision. However, if you then have people who are chefs or gardeners, they're doing a lot more near activity, a lot of artists, I think then you start thinking about doing a monovision trial and giving them modest monovision or a full monovision. And actually, you're quite, as you'll see from the results, that the distance doesn't get affected that much. So it's worth just pushing that boundary and making it to full monovision for these patients. So in conclusion, I think it's a growing segment in my practice, and I'm sure most of you who are into refractive surgery and premium lenses, you will also agree that if you did trifocal 50% before, you're now doing more and more of extended range of focus now. And partly, in my opinion, the reason, so I use both EMV and Vivity, but I feel the one thing which has been quite good for is truly it behaves like an enhanced monofocal. And the reduced dysphotopsia, high contrast sensitivity, and I actually think also I'm getting less chair time because I'm saying to them, at worst, you have to wear some reading glasses for fine reading, and they're fine with it. We don't have to spend that much time talking about dysphotopsia, which is quite an important part of your trifocal sort of consultation. So I think I was speaking to Luca, I was just saying, I am actually going to do, because I think all of us want to know how we can carry on doing EMV or IHANS and Vivity, and I'm starting a study between doing the cost-benefit analysis for the clinic and the patient, which hopefully, watch the space, it'll be arriving soon. Thank you very much for having me. It's lovely to see you. Thank you.